My project is entitled Intervention Through Education, Addressing the Gap Between Provided and Utilized Healthcare in Rural Kenya. So this project stems from fieldwork that I did in the summer of 2014. The goal of this project, before I get into the background of it, is to determine a way in which some kind of public health intervention can be used to address the health-seeking behavior in a very specific target population. So health-seeking behavior is essentially the actions you take when you believe that you need some kind of medical treatment or care. So that could be going to see a doctor, if you're talking to friends or community members, something to address an illness that you've perceived in yourself. So as I mentioned, this whole project stems from fieldwork I did in the summer of 2014. I was in very south-central Kenya in Kimana. The population I was working with lives on the Imbirakani Group Ranch, which you can imagine is very similar to a Native American reservation in the United States. It's a government-allocated tract of land. The population living there is predominantly Maasai, which is an ethnic group in Kenya. And this population has been relatively isolated in comparison to the rest of the country. The first major paved road that linked this area to Mombasa was only completed in 2011. So 3 years before I got there, that cut down the travel time between Mombasa and this area from about 10 hours to 3. So this population has had a very interesting experience with sort of healthcare and health clinics. So there is, of course, government-provided healthcare, but additionally, there was a privately funded clinic. It was run by a woman named Anne Laurie, an American philanthropist. It was the Imbirakani Clinic. It was open from 2002 to 2012. So it provided all types of healthcare for people in the community, including health education, including provision of water treatment chemicals, and it was completely funded by one woman, and unfortunately, it was not a sustainable project. In 2012, Anne Laurie called up the doctors one morning, said, close the doors, lock them behind you, take all the supplies you can, we're done. And essentially, the clinic closed without warning. So this had a pretty negative impact on the health-seeking behavior of the people in the community, because you can imagine, as someone who relied on this, to have it very abruptly taken away is sort of a very negative interaction with healthcare. So to think about Kenya a little bit in a bit of a wider frame, in the post-colonial era, so Kenya became independent in 1963, a lot of the healthcare infrastructure Kenya inherited from the colonial administration. So in the post-colonial era, as independence comes, there's a sweeping movement for Kenyan nationalism. There was a push to really invest in health infrastructure in urban areas and places that were seen as economic hubs. So these were cities, but also places where there was a large number of white settlers. Unfortunately, rural areas like Kimana were largely neglected because they were non-monetized. So they weren't seen as places where development was really going to take hold or that would be very profitable. So the healthcare in these areas, like Kimana, was focused on curative healthcare. So disease breaks out in Kimana, they go in and they treat it as it is. There's no investment in the healthcare infrastructure or preventative care or really health education. So that remained for a significant period of time until we get to about the 1990s. All of a sudden, development is the word in the international system, and low-income countries like Kenya become the focus of many organizations like the United Nations and the World Health Organization, and Kenya gets on track to decentralize its healthcare system. So the goal was to essentially move the authority from the very top of the government, who decided, how many stethoscopes and, what kind of care each center across the country would actually provide, to saying maybe the communities themselves should have more of a say. So in 2010, Kenya passed a new constitution, and that outlined some sort of guidelines for decentralization. And it split the healthcare system itself into 6 tiers. And those tiers correspond to, at the lowest level, community healthcare, the highest level, national healthcare. So you can imagine you go to your local dispensary at the very bottom of the healthcare system, and then you are consistently referred further and further until you need some kind of specialized surgery, and you can only get that at a national hospital. Right now, Kimana and the Imbirakani Group Ranch specifically has 1 dispensary. It has it's supposed to provide care to about 12,500 people. There are 2 nurses on staff. There's a maternity ward, and when I was visiting this dispensary, it was reported that between 2012, the closure of the Imbira County Clinic, and 2014, when I was there had been 7 births in this maternity ward. You can imagine, in a population of 12,000, probably about 6,000 women, there was more than 7 births. Community health workers is another key, a little bit of background about that. Community health workers are people who live in communities. They are essentially liaisons between the community and the healthcare system. So in Kenya, these community health workers are very important because they sort of provide this very interesting chain in the system in which they are volunteers. They are not paid, but they work in mostly rural areas like Kimana. They go in and, monitor families. They can provide very basic medical treatment like burns or taking care of small wounds. And they also do a lot of, informal health education, talking to people about, different important health topics. So when I was in Kimana in 2014, I worked with a research group of about 20 students. We went about our research in 3 ways. We conducted a household survey with women living on the group ranch between the age of 15 and 49, so in their reproductive years, who had at least 1 child under the age of 18. We also did interviews with the members of the district health management team at Olia-Tok-Tok District Hospital, which is a bit higher up. It's about a level 3 care center. And these were people like the chief public health officer, the chief records keeper, so people from the actual formal health care system. We also did focus group discussions with members of the community. These were sort of high-ranking community members who, some were essentially in the position of what they refer to as village chiefs, or people who hold a lot of sway on the group branch. From this data, we analyzed it as a group, and I've taken 3 issue areas, which I believe are the most pertinent based on the data and the interviews we conducted. And these are maternal health, child health, and water and sanitation. In my paper within this, I get a little bit more specific. And I also, a lot of my research had to do with past examples of interventions, so looking at what other organizations do, because I do not want to or need to reinvent the wheel if there are interventions that are working already. So in my paper, I propose a sort of flexible framework, because obviously not an expert, so not saying that I'm going to have this very comprehensive program that would, fix rural healthcare, obviously. So basically what I've done is taken some past examples and my own data and designed a program that would serve as an intervention that uses education and community health workers to bring people information. Because what I think my big takeaway is that the real problem is that there's a local population that knows that they have health issues, but they don't necessarily have the information available to know, how do I access the healthcare system? What services are available to me? Where do I go? And so I think that, through my project, that's what I've really looked at. And 3 really quick areas of concern that came up as I was sort of developing this program: the idea of sustainability. Especially with the experience of Anne Laurie in this community, people have a very distinct idea of programs or perception of programs that come from outside the community. So any program that is an intervention in health, I believe, has to be sustainable. You have to think in the long term, define what is the long term, because to go in and do more harm than good is obviously not our goal. Funding, this program that I have sort of envisioned is a very relatively low requirement for funding. It's mostly compensation for community health workers. There's also a cultural acknowledgement. As I mentioned, this population is predominantly Maasai, so of course there are certain, cultural practices that have to be taken into account, whether that is how it affects people's health-seeking behavior or issues that affect people's health. Probably the biggest issue in my actual development was determining what kind of information dissemination I was going to include. So when I was visiting the Imbira County Clinic, which is closed, all the posters were in English, which is a problem because most people who live on the group ranch do not speak English. They speak Swahili or Kimasai, and they don't typically read either. And so this issue, and what we heard from a lot of people was, we see pamphlets or posters, but why are they not they're not accessible to us? So one of the past interventions I looked at was, it's a very popular, actually, method that's been used by several organizations in Uganda, and it's the use of song or dance or theater to sort of promote health information. And I thought that this would be great because in Maasai culture, dancing and song are very important for storytelling and for passing information to different people. Also in the program, talking about community health workers, there is a dormant network of community health workers in Kimana from the time of the Mbirikani Clinic. They were extremely well-trained and extremely well-organized. They actually still, from many of the community health workers I talked to, they still visit and monitor the same families that they worked with several years ago, because those ties don't just, dissolve overnight. These are well-trusted people, and they're seen really in the community as very knowledgeable and very helpful. So training community health workers, there's a lot of organizations that do this. AMREF Health Africa has a very rigorous, it's a very rigorous program for not a whole lot of information. It's about a several-week program that people attend, so I don't, like I said, want to reinvent the wheel. That wasn't my goal. So sort of outsourcing that, it's also a cost-saving measure in this kind of program. CAs are community ambassadors, so these are the people who are in the focus group discussion. They can lend legitimacy to this program through their support. So, just by answering questions or talking about it can show people that they can actually, trust these kinds of programs. So moving forward, basically, when I talked about goals in my paper, I wanted to look at big picture, could a program like this exist in an international system that really focuses on the state as the be-all, end-all, who provides care? The government provides healthcare, provides education. Is this a possibility? I think that ties in with political implications, which is if you have small-scale programs that are localized, that succeed in dealing with issues that governments at times struggle to deal with, does that sort of undermine governmental authority? How does the government interact with these programs? And I also, in terms of future research, I would really love to, continue this kind of work and look at doing more in-depth research, continuing this research study. It actually continued another year after I conducted my research. It was a long-term study. Unfortunately, the program, the research camp I lived at was closed because of security concerns in the country. So unfortunately, it won't be continued by this program, but hopefully someone else will take it up in the future. So I just want to say thank you to everyone for sticking around this late in the day, to my advisor, Professor Longman, coming in on a Sunday and helping me throughout this whole process, all the professors in KHC, and also the women in my study. This is a group of Maasai women who we spoke to. They let us come into their homes for an hour and talk to them about incredibly sensitive information, and they never once said, this is silly, or they let us really explore these topics and have honest, frank conversations. So without these women, this project would not have ever taken hold. So thank you. Anyone has any quick questions? I think we're about out of time. Yeah, Ryan.
You're looking at funding and sustainability. Do you look at funding for resources like medication, supplies, for all these treatments, or just focus on more of the community health going to the community education aspect?
I focus mostly on the sort of the latter. So we're looking at compensation for community health workers, which I looked at in terms of airtime minutes for cell phones, which was something I found when I spoke to the community health workers from the Mbirikani Clinic. They said that was one thing that they wished that they still had, that was a resource they had been given before, because they do, they contact people. I think people have also a perception that this is a very rural area. Everyone has a cell phone. So, they really keep in contact with the families they monitor through cell phone communication. So things like, cell phone minutes, but also administrative, like printing materials. I didn't look at sort of grants and that kind of funding for supplying medication or more concrete supplies. Just based on the previous experience of this community and the project that I was pursuing, I didn't feel it was a sustainable project to say, you go in and give vaccines and that's great, because that's only great if it's provided in the long term. And the government already has a very, the government has a healthcare system. I didn't, especially in resource limited contexts, didn't want to compete with that, so.